kinds of health goods and services are consumed, and in this case we look at inpatient versus outpatient services. Who are the providers of services? That's our service provision interface, which looks at whether we are looking at hospitals, laboratories. We have our financing scheme, which answers how are goods and services paid for.
This is something interesting because in Belize, our male to female ratio is almost the same. So that poses, that's quite interesting. Now, the good thing about that is that the females of my generation, most of them are professionals, because our boys, like in the Caribbean, are all falling through the cracks. You go to any junior college, university. In fact, I think for the first time in Belize, the male-female ratio of physicians are practically coming 1-1.
Currently, we're spending 3.4%, conceivably asking us to double public health spending. You know, that is what we would be looking at. The thing is, because we have such a large out-of-pocket spending, there is, as it were, a captive pool of spending that we could be aspiring to bring into some kind of prepayment program. And once you do that, then you can account for it as, it would then be accounted for as public spending. So we do need to have mechanism to bring in all of this out of pocket into prepayment plans. And then again, that's of course what we would intend to do with our national health insurance.
The coding I do, I only code what I'm going to get paid for. Right, and which doesn't help in terms of some of the data that's received. If you're only going to pay based on what you think you're going to get the most money for, you're not giving a good reflection of what you're doing. Claims data does not answer the why question, it only gives a sense of what it is. Then you have to go back and you have to talk to people and get what the why things are happening.
What I would like to show is the business case behind this project. Because what is transmural diabetes care is actually investing in primary care so that patients are more compliant to treatment, investing in knowledge education, and we decided not to expand the number of GPs but to invest in nurse practitioners.
The economic return was reduced emergency rooms and increased participation in the workforce. Very simple indicators. Didn't take into the account other sort of returns, social welfare returns, secondary returns from improved response to physical health care, law enforcement costs. The health returns are a very big deal because when you have early intervention, when you have increased remission rates, what you have over time is a reduced prevalence in your population. So the value of that reduced prevalence is important to consider in terms of your future costs going forward.
What would be the next step in these conferences? This is your 11th year, and while, especially I think in healthcare, there's always new things coming, there's always innovation, so there will always be things to talk about, new technologies, etc. But I guess there's a question in terms of where you're going to go with this, because I've seen too often in these conferences that people come and they're highly motivated, they're charged up, they're pumped up, but then they go home, they got to make dinner for the kids and they got to go back to their job, and very quickly they get sucked into their daily routine, and all of the inspiration and lessons learned tend to get put on the back burner. And I think that's a shame because, again, I've seen the energy, the enthusiasm that's here in this conference. And so I would ask the organizers to think a little bit in terms of where you're going, in terms of what your objectives are, what the goals are. And I suspect, as I've heard around the room, there's some degree of question in terms of what impacts need to be made in terms of policies, because eventually, for all the efficiencies that you can garner from each other and all the lessons that you can learn, at a certain moment, you're going to hit a wall where you're going to deal with politicians and policies, and those may not jive, they may not match the business plans.
I learned that there are new issues that I haven't thought about before. And one of these issues is that indeed in the Caribbean, with so many, relatively small islands, small and larger and smaller, often in healthcare you are working below the optimal skill. And that's a very specific problem for all the Caribbean islands, for most of them. Below the optimal skill when it comes to high medical technology, purchasing care. And that brings me to the first issue, that it seems very logical that you can win a lot by cooperation within the area. For instance, in the field of purchasing care overseas, you all have the same problem. Why not joining? You are much more powerful. Or when you purchase IT, which is very expensive and complex, join the forces and then you can have the experts on that area. Or purchasing pharmaceuticals, telemedicine, which undoubtedly is coming up. And these islands are the first to profit from telemedicine and all the new technologies that are.
Number of countries have grown from 16. We've sort of moved a little bit in between, but in Bonaire in 2016, at our 11 country conference, 24 country representatives from 24 countries have actually showed up over here. Organizations which have been present outside of Social Security, Ministry of Health and Health Financing. We have 14 organizations, starting with 3 to 14 organizations. Participants who have been in the room most of the time, and note that in bracket, most of the time, because there's some who have flitted in and out at particular moments, but most of the time we've had 110 persons in Bonaire, the largest amount we've had in all of the conferences. And ministers as participants, or most of the time. We have moved between 1 and 2. We're very, very happy and very, very thankful that Minister Lee has stayed with us throughout all of the sessions. All right, really. What are the kind of matters that we got into? We have country plans, which we've discussed, country proposals for changes for new health insurance and other health financing arrangements. We've had a mix of feature papers by feature speakers, Professor Van de Ven and company, as well as panel presentations where we gave individual countries a chance to express their own views on the situation operationally on the ground.
We were proud and happy to have been able to organize this conference. We liked it very much, and it's a success, apparently. There are always a lot of people who are important and to make a success of such a conference. In the first place, the participants, the speakers, the level of the papers presented. But beside that, there are always a lot of people who are individually making big contributions. I think it's already mentioned that Dr. Laita is a very important factor in that, so a big applause for him. And not to forget the founding father, Professor Theodore. But ladies and gentlemen, there are always people in the backstage. People who have working for months to make a success of it, who have sleepless nights, who have been soaked wet in the rain to give you lunch. And I would like to have those people here at the front. I would like to have, for instance, Wendy de Vries, Bob Harms, Manon van der Heijden. Where is Manon van der Heijden? Valerie Martens, present. And Charlene, where is she? Where's Charlene? Yeah. Ladies and gentlemen, as I told you, these are the people who have had sleepless nights. So I think they have been the crucial factor to make a big success of this conference. I would like to give them a small present, but I think it's enough now to give them one last applause, and then we go to lunch.